Hello students, welcome here. Today we are going to talk about public health in India, its evolution, structure, achievements and limitations. This is a very important and interesting topic, and you may remember in the previous lecture we talked about evolution of public health as a concept and as a phenomenon at a global level. So today we are going to focus on Indian context. And yes, this lecture is divided in 4 sections: understanding evolution of public health in India, then report of various committees which actually help in development of public health structure in India, then the specific structure of public health and specific achievements, main achievements, and then finally the concerns and limitations of public health in India. So yes, these 4 sections will focus on, and now we move to the next part. And as we discussed in the previous lecture, basically we do need to have some kind of understanding on how the concept of public health developed globally. So a very brief recapitulation. Actually, public health as a concept developed in United Kingdom in the mid of 19th century, and the United Kingdom's Public Health Act of 1848 is considered as the most important policy act or a legal document which was passed by the Health Ministry of England and Wales, right? And it talked about specific components which were different from the conventional health related issues. So this public health talked about the drainage and provision of sewers. Then it talked about removal of all refuse from houses, streets and roads, then provision of clean drinking water, and then medical officers. So this is a different move. Then the Public Health Act of 1875, these two acts actually helped in growth of the notion of public health in the United Kingdom. Similarly, we see that in the US in 1889, the Public Health Service Commission Corps was established, and public health service in 1912 basically got institutionalized. That means by the end of 19th century and early 20th century, the notion of public health became established in United States. So this is the global position that we have discussed at length in the previous lecture. And then basically it is relevant to remember WHO's definition of public health, because whenever we talk about public health, even if in Indian context, we need to have some point of departure, and this WHO's definition is actually a point of departure. So the expert committee of WHO on public health administration in 1952 has defined public health as the science and art of preventing disease, prolonging life, and promoting mental and physical health and efficiency through organized community effort for the sanitation of the environment, the control of communicable infection, the education of the individual's personal hygiene, the organization of medical and nursing services for early diagnosis and preventive treatment of disease, the development of the social machinery to ensure to every individual a standard of living adequate for the maintenance of health, and so organizing these benefits as to enable every citizen to realize his birthright of health and longevity. So what is clear from this definition, that public health is actually not the conventional health related intervention of a government or health related intervention of biomedicine or medical science. It goes beyond biomedicine, it goes beyond the system of medicine, it goes beyond the system of healthcare, and it takes into consideration the larger macro environment, and it goes beyond actually this medical science, because even the WHO definition is saying that it is a science and art of handling so many things. So this is the larger canvas. We need to keep in mind this thing. And then basically when we talk in context of WHO, then we know that WHO is always having a comprehensive approach. Its definition of health also includes multiple dimensions like physical, mental, spiritual dimensions, social dimensions, and it also talks about occupation and emotions. So these are this is how the WHO has defined health. And then there are important milestones that we need to remember, because whenever we will talk about public health, we need to keep in mind those milestones as decided by WHO or United Nations or all global agencies. In 1978, basically, WHO talked about health for all, and that is most important thing, because unless we start thinking in terms of providing health services to all, we don't need to talk about these larger structures. The utility of the concept of public health basically becomes very important when we have that kind of goal, that we are talking about health for all. Similarly, the Millennium Development Goal of 2000 and the Sustainable Development Goal of 2015-30, these are also milestones which talk about some sort of health for all kind of agenda, or universal access to healthcare and other things. So this is the background. So we understand public health, we understand what are the global milestones. Now we come to public health in India. Now, basically, India has witnessed evolution of several traditional medicines and healthcare system. We know, we have taken up a lecture on Ayush, and we know that the Ayurveda system of medicine, or Unani system of medicine, or yoga, Siddha, etc., developed India or in other parts of the world, but they are all established as traditional system of medicine in India. So the history is basically very old, but these are not conceptualized as public health as such. These are understood as different systems of medicine. Public health is more than this. What happens that most of the time when somebody is talking about public health, they begin with all those traditional system of medicine, or maybe the biomedicine. We are not talking about those. We have talked about those things separately. Now we are talking about the larger environment. Of course, these traditional system of medicine or Western system of medicine are component of that, part of that, but the public health is not confined to them, right? Public health is much more than that, and we are trying to understand that larger thing. So under the Constitution of India, public health is shared responsibility of the center, state, and local levels of government. We know the federal structure, we know the importance of the local government democratic system. So basically this is divided at three levels: the center, and the states, and the local government, self-government, and public health is a responsibility of all the three. However, health as such is a responsibility of the state. So we can see the differences very well. Public health means at the union level, at the state level, and at the local level. Health primarily, as per the constitution, is the responsibility of the state, but yes, the center is also having several regulations related to this. But the local governments as such are not having that kind of responsibility related to health issues. Although we know that the 73rd and 74th constitutional amendment have played very important role in ensuring democratic decentralization, in empowering the local administration or local self-government. And these local self-government have been assigned very important responsibility from the perspective of public health. Then we try to understand a few other things. The amount of public health spending is not uniform throughout the country, but the state and local government account for 3/4 of the total public health spending. So primarily, state and local government account for 3/4 of the public health spending. A little amount is invested by the central government also. And then some of these are taken care of by people themselves also. The government of India, after independence, appointed various committees of experts on health in order to look properly in health sector and suggest recommendations to overcome the health problems and improve the health status of population. One of such committees, Borah Committee, was appointed even before independence of India, and it has truly left lasting impact. So basically, there are several committees. Any student of medical science is aware of those things, but basically student of social sciences and students of public health need to know about these committees and their reports, because they actually reflect the trajectory of growth of or emergence of public health in India. So, the Borah Committee, known as the Health Survey and Development Committee, was appointed in 1943, much before then 1947, when India became independent. It was appointed in 1943 and submitted its report in 1946. It laid emphasis on integration of curative and preventive medicine at all levels. So basically, this committee has suggested to integrate curative and preventive. Curative medicine, basically, sometimes we also refer this as clinical and preventive medicine. We have understood the differences between these concepts in our earlier lectures, so we won't go to the conceptual things. An important suggestion here is to integrate these two. Then it suggested development of primary health center manned by, no, basically Borah Committee is talking about development of primary health center, and it suggests the composition of the primary health center, and this composition is very important. It's very important because we need to understand what kind of component of or constituents of primary health center needs to be there. It should be manned by 2 doctors, 1 nurse, 4 public health nurse. Now, this public health nurse is something that we need to understand. Then 4 midwives, 4 trained dye, 2 sanitary inspector. Now, the role of the sanitary inspector is visible here. Then 2 health assistant, 1 pharmacist, and 15 other class 4 employees for a population of 40,000, and secondary health center to provide support to PHC and to coordinate and supervise their functioning. So in India, we are much familiar with the notion of primary health center and Subcenter, but basically the idea of primary health center and Subcenter finds its origin in the Borah Committee, and a composition is suggested from the perspective of public health. However, as we know that those structures are not being followed. We'll come to those things at a later stage. The Borah Committee also recommended major changes in medical education, which includes 3-month training in preventive and social medicine to prepare social physicians. So it also talks about a specific kind of training in preventive and social medicine, because we need to understand that unless we focus on preventive medicine, actually we cannot achieve the goals of health for all, because depending upon curative medicine basically means depending upon the diseases to occur, right? Preventive medicine actually talks about prevention from occurrence of the disease. So this was the comprehensive report of Borah Committee, and then Modalia Committee was constituted in 1962. The Modalia Committee was appointed to assess the performance of health sector since the submission of Borah Committee report, and it advised that the primary health centers, subdivisional and district hospital should be strengthened, and they should provide preventive, curative, and promotive services. So 1962 report submitted by Modalia Committee is talking about some kind of assessment of the report of the situations after Borah Committee, and then it advised that the PHC, the subdivisional and district hospitals should be strengthened. That means we are here stating that some kind of health structure is existing at subdivisional and district level. And then it also talks about that integration of preventive, curative, and promotive services. So promotive means basically those services which promote the health outcome of people. We have already understood promotive health in our previous lecture. Then comes the next committee, that is the Chadda Committee. In the year 1963, the necessary arrangement for maintenance phase of National Malaria Eradication Program. Now, here we see that this committee is talking about specific things, and it talks about the maintenance phase of the National Malaria Eradication Program, and then also talks about vigilance activity in the National Malaria Eradication Program should be carried out by basic health workers, 1 per 10,000 population. So now we need to understand that by 1960s, actually there were specific measures to address the problem related to malaria eradication. We will talk about this program at a later stage, but as of now, it would be to say that this committee actually talked about how to eradicate the problem of malaria. This is a disease control program. That means a diversification in the functioning of the overall health structure has started, right? Then Mukherjee Committee It was primarily meant to review the performance in the area of family planning. The committee also recommended to delink malaria activities from family planning. Now, family planning basically became very important goal after independence of India, 1950s and 60s, because of the focus of the government on population control measures. But some kind of health structure was required. Till then, uh, the because of the prevalence of vertical disease control program, the government of India was not having very established healthcare structures. Although we talked about the primary health center and sub-centers, but those were not very established, not visible. So what was happening, that whatever structures were existing, those were actually interested with new kind of work. So the malaria eradication structures were also assigned the responsibility related to family planning, and hence this committee recommended to delink the malaria activities from the family planning. I mean, staff should be differentiated. Then the Judge Jungarwala Committee, it recommended integration of curative and preventive health services by the state in such a manner that the teaching and research department is uh, it is mentioned as affected. I think I need to check it. So basically, we need to check it. The committee recommends integration of curative and preventive health services by the state. We'll focus on this part only. Integration of curative and preventive health by the state. And basically, it makes provisions related to teaching and research departments. So till now, we have not been talking about the state of the medical colleges, the teaching and research departments, and this committee has made specific recommendations related to growth of medical education and especially medical research. So what we are saying, that the different committees are talking about different issues related to growth of health facility or medical services in India, and some of these are also talking about the public health or the diversification of the public health. Then we have the Kartar Singh Committee. Its main recommendation was, we've talked about only two here. Various categories of peripheral workers should be combined into single cadre of multi-purpose worker. It talks about some kind of developing a structure related to multi-purpose worker, and then one primary health center should cover population of 50,000. It should be divided into 16 sub-centers. However, we'll come to the existing primary healthcare center and sub-centers structure at a later stage. The point is this, that some kind of composition of the primary health center, sub-center, then the population that will be addressed, these things are coming into existence, these things are evolving. That's why we are talking about the evolution of public health structure in India. Then Srivastav Committee, it was set up in 1974 as a group of medical education and support manpower. So basically, it talks about medical education and manpower. Then the Bajaj Committee, an Apex Committee for Health, Manpower Planning, Production and Management. So these things are there. I must also say that in 1983, first health policy came into existence, and then 2002, another health policy came into existence. So on the one hand, there are recommendations of several committees. We talk about some kind of diversification, talk about some kind of growth of the public health structure and especially the health structure in India. And there are several other simultaneous development. So what kind of health structure actually came into existence after the recommendations of these committees? If you want to understand the overall public health structure or the health structure in India, then basically we need to focus on these things. Let me share with you here that although we talk about public health, but in India, we do not have much established structures related to public health. So public health structure or public health concept is not much visible in India. We have taken up this point at the end of the lecture. So because public health talks about several things, it also talks about the health structure. So let us try to understand whatever structures are available, and if the health structure is there, we need to understand that also. So the health sector in India is characterized by primarily two things, the government sector and the private sector. Now, sometimes, as we have discussed in the previous lecture, sometimes people think that public health means actually the government health structure only. No, it is not like this. Public health is taking into consideration both the government as well as private health structure, but it is not keeping itself confined to health structure. It goes beyond this health structure or healthcare structure. It talks about the larger macro environment, and in this macro environment, healthcare system is also a part of this. So here we are talking about this healthcare system. Now there are national level and state level and then local level structures. At the national level, as of today, we know that there are two actually ministry. One is the Ministry of Health and Family Welfare, and the second is the Ministry of Ayush. Ayush is basically an acronym, and it refers to Ayurveda, then yoga and naturopathy, Unani, then Siddha and homeopathy. Earlier it was known by a different name, but as of today it is known as Ministry of Ayush. So this is the structure at the union level, at the central level, that there are two ministries. Then by and large, the organizational structure adopted by the state is in conformity with the pattern of the central government. The state is also having some similar kind of a structure. Basically, ministries are there, and as we know, health is a state issue in India. So there are health-related ministries and structures are prevailing. Then we come to the district level. The district officer with the overall control is designated as Chief Medical and Health Officer, CMNHO, also known as CMHO, or the District Medical and Health Officer, and is overall in charge of health and family welfare programs in the district level. So basically, at the operational level, we see that the district level, there are chief medical and health officer who are responsible. And in our day-to-day life, we also observe the position of the CHMO or the district medical and health officer, that is DM and HO. Then we have the community level structures. One community health structure, one which is primarily identified as community health center, CHC, has been established for every 80,000 to 1,20,000 population. But this CHC or the community health center is one of the most important and visible structure of healthcare in India. Everybody is familiar with CHC or the functioning of the CHC. It is primarily established for every 80,000 to 1,20,000 population, and this center provides the basic specialty services in general medicine, pediatrics, surgery, obstetrics, and gynecology. The CSCs are established by upgrading the sub-district. I mean, there are how do these come into existence? Through upgradation of certain structures, etc. So that's a different issue. Then after having this community level structures, the most visible structure, that is the primary health center or the public health center. But sometimes, although we address this as public health center, it is actually primary health center. We should not confuse it as public health center. Sometimes when talking to some of the medicos, we often hear these words, but we need to be cautious and careful about these things. These are actually, PHCs are actually the primary health care centers. WHO has also given its guidelines on PHC. However, what is operationalized in India is not exact replica of the WHO guidelines. It differs from the WHO guidelines. So primarily the PHC in India is covering around 30,000 people. It varies in a specific context. Many rural dispensaries have been upgraded to create these PSCs. Each PSC has one medical officer, two health assistant, one male and one female, and the health workers and support staff. For strengthening preventive and promotive aspects of healthcare, a post of community health officer was proposed to be provided at each new PSC, but most states didn't take it up. Uh, these days, these PSCs are also having people who are trained in the Ayush system of medicine. in many states. Then we have the subcenter. The most peripheral health institutional facility is the subcenter, manned by one male and one female multi-purpose health worker. At present, in most places, there is one subcenter for about 5,000 population. The number is again varying in the specific context. Primarily, this is the sub kind of, you can say, the first structure, the first visible site of healthcare in the form of subcenter. And then comes the local bodies. The 73rd and the 74th constitutional amendment have given the power to the local bodies in some states of India. As of today, we can say that in the most of the states, in the process, different states have adopted different stakeholders for the benefit of health services with the help of community participation, which gives a stress on safe drinking water, sanitation at village level. The panchayats are given the power to look after the welfare of the people. So primarily, we have stated that there are district level and then community level, then uh, village level structures are present, that which are primarily the healthcare structures. But if we go beyond this and we talk about the public health, then the public health structure, as we will discuss soon in other sections also, is the local self-governments are assigned some of the very important responsibilities related to public health. For example, the provision of providing safe drinking water. This is related to the municipalities or the panchayat level structures, or for that matter, the street light or construction of roads and streets. These are related with the local self-government or the municipal bodies. So these facilities, even the school, primary education kind of thing, these are the important components. Basically, you can say that when we talk about public health, we talk about food and nutrition, we talk about education, we talk about electricity, we talk about civil system. All these responsibilities are taken care of by the local self-government bodies or the panchayati raj bodies. Although these are not much visible in the at the level of the panchayats, but these are very visible at the level of the local self-government bodies. So now, after having some kind of understanding of the public health structure, we need to understand what are the achievements. If we want to see the achievements, then one very important report is there. This is the report of the expert committee on public health system. It was, the report was submitted in 1996. It was also headed by J.S. Bajaj. And this report very categorically actually makes a comparison between the health condition which was prevailing in the mid of the 90s and conditions which prevailed in mid 40s at the time of the independence. And we need to have some kind of understanding. This is very important. By the time India achieved independence, socio-political and economic degradation reached to an extent where hunger and malnutrition was almost universal. 50% of the children died before the age of 5. This is the indicator that we need to remember. When we talk about achievements of public health, we need to remember that what was existing at the time of independence. 50% of the children died before the age of 5. Primary health care was very rudimentary or almost non-existent, and the state of public health was utterly poor, as evidenced through life expectancy at birth around 26. Life expectancy at birth was around 26 at that point of time, and we know that it is around 71, 72 in various states of India. So we have moved, significantly. Infant mortality rate was 162, crude death rate around 22, maternal mortality rate around 20. That means the indicators of public health and health outcome were very poor at that point of time. Then only 4.5% of the total population had access to safe water. Now, when we're talking about water facility, there was very, 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 very limited kind of accessibility. Only less than 5% people had access to safe water, and only 2% of the people had sewerage facility. Then number of medical institutions was few, and trained para-professionals like nurses, midwives, sanitary inspectors were barely visible. Then the picture on the nutrition front was very grave. Food production, its distribution, availability of food per capita were all unsatisfactory. The MCS services, school health services, healthcare facilities for the industrial worker, environmental health were all far from satisfactory. That means if we focus on the public health scenario in 1947 or and early 1950s, the situation was very difficult. So what happened in the past 7 decades, we have made several improvements, and this report, which was submitted in 1990s, 1996 specifically, talks about the conditions which prevailed in 1947, which are, I mean, beyond imagination as of today. So actually, whatever achievements we are having today, if we want to understand, and basically if we want to count the achievements of public health intervention, then we need to go for some specific interventions. What were those specific interventions? As we stated, that basically Government of India uh, tried to improve the water facility, then sanitation facility, then the sewer system facility, because we know that diseases like malaria, for malaria we don't need medicines as such, because these medicines are only taking care of the curative part, although malaria needs some kind of prevention, right? So for eradication or control of malaria, we need to have preventive programs, and for that the macro level interventions are required. So we had several vertical disease control program, and all these disease control program are actually very important programs when we see in terms of the public health interventions in India. Here I have mentioned some of the specific programs. I won't go into details, but yes, the contents are very obvious and visible. The National Malaria Control Program was launched by the Government of India in 1953, and it was converted into National Malaria Eradication. So earlier we need to understand these two words, control and eradication. So in 1953, we tried to control it, and later on we tried to eradicate it. Then National Leprosy Control Program was launched by Government of India in 1955, and we can see that the program was redesigned into National Leprosy Eradication Program in 1983. So it takes time when we think of controlling and when we think of eradicating. I hope this point is well noticed by all of you. Then to control tuberculosis, we had National Tuberculosis Control Program, again way back 1962. And then the Government of India is implementing the National Iodine Deficiency Disorder Program, right? Iodine Deficiency Program. And as of today, we know that in India, we are using salts which are actually iodized salt. Now, this is the public health intervention. This is how we can understand that how basic the target is very obvious. We need to create an environment which is free from disease, and every possible intervention needs to be taken care of. So if we can provide iodine to people, then salt, combining it with salt, is a big public health intervention kind of thing. And then National Cancer Control Program was launched in 1975 and 76, and we know that even today cancer is one of the biggest cause of, most important cause of mortality, rather you can say premature mortality. Then we also had interventions related to mental health program. We had the National Mental Health Program in 1982, then Kala Azar Control Program in 1991, and then National AIDS Control Program way back in 1992. So after talking about these disease control program, we need to talk about one specific massive program. This is actually the National Rural Health Mission. It was started in 2005. Earlier I talked about the health policies also. So we had the first health policy in 1983 after the Alma Ata Declaration, and that policy basically talked about achieving the goal of health for all. And then in 2002 we had another health policy, and 2002, that means turn of the millennium, we had the Millennium Development Goals, and here focus was on several other things, right? And in between, one more important development happened, that we had this Human Development Index, and Human Development actually talked about integrating health index into the development index. So because of the international and national level compulsions, Government of India launched a massive program which is considered as a paradigm shift program. This is known as National Rural Health Mission 2005-12. Well, some of you are familiar with all these things. One very important thing, or rather two important things that I need to talk about here is this program made a specific provision for integration of the health structure with the panchayat structures. We are already familiar that that in 1993, basically the 73rd and 74th constitutional amendment talked about the local self-government institutions, and now this national health National Rural Health Mission, which later on became National Health Mission, also included the urban poor. So this program basically focused, or rather you can say aligned with the democratic institutions like the local self-governments. And then it talked about ASHA. ASHA is a very important intervention, uh, and I think all of you are familiar with the functioning of the ASHA, right? ASHA is an health activist, right? And then the main focus was to make primary health care visible, the sub-centers visible, to provide the specific uh, facilities related to infrastructure, and then to staff, to provide the staff, right? Because otherwise, those primary health centers were primarily not fully staffed. And then there were some core strategies. I just want to read some of those core strategies because that will help us to understand the priorities. To train and enhance capacity of Panchayati Raj institutions in order to own, control, and manage public health services. Now, the word public health services is very categorically mentioned. So, this is important to train and enhance capacity of Panchayati Raj institution. If anybody is asking you which agencies are actually important in maintaining or providing public health services in India, certainly you can say that it's the local self-government, it's the Panchayati Raj institutions and the municipal corporations, right? This NRHM is categorically talking about this Panchayati Raj institutions. Then promote health cadre at household through female health activists, that is ASHA. Then health plan for each village through village health committees. Now these village health committees became the village health and sanitation committee. Some kind of a structure should be existing at the village level. Village health and sanitation committee will be responsible for taking care of health and sanitation need at the village level. Then strengthening the sub-centers through unified fund, and then implementation of intersectoral district health plan, then supplementary strategy, and several other things. It also talks about mainstreaming the Ayush program, right? As of today, we know that we have one specific ministry related to Ayush, and there are several colleges. We have already talked about this when talking about medical pluralism in Indian context. So after having this broader understanding, very precisely we talk about the limitations. What are the limitations of public health in India? There are several limitations. Basically, the achievements are many, but these are much lesser than what we should have attained. As of today in India, there are several health-related problems. But if we look at the public health related issues, then some of these limitations we have identified. Instead of talking about the problems, we are talking about the limitations because we need to overcome these limitations. The first thing, the sectoral planning and the sectoral planning system means that at the ministry level, at the central level, or the state level, the federal, because of federal structure, basically we have divided several sectors and we do not have intersectoral departments. So public health is an umbrella kind of situation which needs intervention from several departments, but that is actually not that visible in India. And then basically issues related to drinking water, sanitation, food and nutrition, housing, electricity, environment, etc. are taken care of separately, and we do not find unified structures related to them, although the functioning are overlapping and almost interdependent. Then because of this existence of separate structures, sometimes we can see that there is a lack of coordination among these components. Then excessive dependence on out-of-pocket expenditure. Basically, we have not taken up the issues related to health expenditure, but unfortunately in India, almost 80% of the health expenditure is actually out of pocket expenditure. So this public health uh, components or constituents which are identified, we are not in a position to provide a specific data related to the funds, because the funds are much meager and not readily available in public domain in under the heading of public health. Then lack of functional awareness on health issues. If we talk about primary health care, then WHO guidelines also talk about providing health education. And this is one of the very important component of public health, to provide health awareness and education. But unfortunately, this component is having very limited performance in India. Then weak and fragile healthcare system. Even the healthcare system that we have is not very strengthened. It's weak and fragile. And during this COVID outcome, we have assessed the health structures, and we see that many states are having actually poor performance in terms of having health structure. Then huge burden of communicable disease. Yes, in India till recently, the mortality is caused because of communicable disease is much higher than the non-communicable till few years back. And this is very pathetic condition related to health structure and control over the communicable disease. That means the overall health structure is also not very sound in India. And policy initiatives, there is yes, dearth of policy initiative. And although we had the global targets in the form of Millennium Development Goal, or now we have the SDGs, but we could not achieve the goals of MDGs in the specific time frame. We may talk about these MDGs at a later stage. And then structured inequality. Actually, the biggest problem that India is having kind of social and structural level inequalities. And what happened that these inequalities become get integrated with the social inequalities and health inequalities. So unfortunately, the social structure is having or witnessing several cleavages or cracks or inequalities, and these inequalities get intermixed or overlapped with health inequalities, creating a very pathetic situation. What is happening that those who are socially and economically marginalized are having worst kind of health outcome, which is very problematic, very disturbed. We can see that health of children, aged people, and women are actually problematic. Similarly, health of the scheduled caste and scheduled tribes and other economically and socially vulnerable groups are not very well. So this is the overall scenario related to public health in India. We have tried to understand important things in this context. And before I close, I must say that issues related to housing, electricity, environment, then sanitation and food and nutrition need a specific probing, and we have tried to understand these things separately. And in my book and in this lecture series also, I'll try to examine some of them separately. So thank you very much for being with me. Do leave your comments, and if you're watching it on YouTube, then certainly like it and share it so that it can reach to maximum number of needful people. Thank you very much. So I am stopping sharing of the file, and then I'm closing the